This is a PowerPoint about SARS-CoV-2 and multi-system organ failure. The objectives of this PowerPoint is to describe viruses, explain the SARS-CoV-19 pathology and cause, how it affects other organs such as the renal system, the pulmonary system, its effects on the cardiovascular system, and finally the treatment. Viruses are extremely simple microorganisms. The basic viral structure consists of the nucleic acid, which is DNA or RNA. They are protected by a protein shell called the capsid. The capsid may take many characteristic shapes. They can be either helical, isohedral, or large pleomorphic, such as pox viruses. Some viruses have a protective envelope surrounding the capsid, which consists of the plasma membrane from previously infected cells. Viruses don't possess any of the metabolic organelles found in bacteria or other human cells. They have, again, a very basic structure. The capsid has the different shapes as shown and depicted in this picture on the right. You can see that there's a cone type, rod type, helical shape with the RNA here. You have the polyhedral or hexagon type shape with a few spears on the outside and the DNA or RNA on the inside. And then you have the sphere shape that's more like the SARS-CoV-2 that has the DNA or RNA actually on the inside, the single strand. It has a capsid that's covering it. It's one of the few that has the envelope on the outside, and it is known by the spikes of glycoprotein that's on the outer surface of this virus. And there's also a very rare complex type that's called a bacteriophage. Viruses are the most common afflictions of humans. Transmission can be either direct or indirect. An example of direct contact would be if the virus was in an animal. Indirect would be if you got it from someone coughing on you. The viral life cycle is completely intracellular. This means that they need a host to be inside, such as depicted here in this slide. On the right, you can see that. There's several steps involved. The first step here is the attachment of the target cell and the penetration. As you can see here, the SARS-CoV is attaching to the outer membrane of the epithelial cell. The second stage is the uncoating or replication, and the third is assembly. These two sort of go together. There's this replication and uncoating that's happening here, and the assembly that's happening in 3. They're both sort of happening at the same time. Once it gets inside the cell, that uncoating happens, and it's assembling itself to be released, and the viral RNA enters the nucleus where it is replicated. And stage 4 is the release by lysis or budding. So once 3 and 4 are done, the viral mRNA is used to make viral proteins, and it gets in the nucleus. As you can see here in 2, it's not there yet. But once it does get in the nucleus and it's replicated, it is then released by lysis and budding out into the intravascular space where it infects other cells. Coronaviruses are single-stranded positive sense RNA viruses. As you can see here, single-strand RNA. It's named for their crown-like spikes on the surface. You can see the spikes going off all around. They have a very high capacity for mutation, as we're seeing now with the variations of the UK variant and the South African variant. That's happened in less than a year. We have 2 different variants currently that's happening in the world. So we know that they have a high capacity for mutation. They contain 4 major structural proteins: the S spike, the N protein, the N protein or nucleocapsid, the M protein, and the E protein. And that's what's depicted here on this picture. The S spike, the nucleocapsid coming down here, the M protein membrane, and the envelope. This is one of the few viruses that has an envelope. Not all viruses have that. There are 7 different strains of the coronavirus that's known to infect humans, and most of them don't usually cause serious disease. However, the SARS-CoV can be lethal. The MERS-CoV of 2012 is the Middle East Respiratory Syndrome coronavirus. The SARS-CoV uses the ACE2 as the receptor host to enter the host cell. The transmission is by respiratory droplet via close to person contact, and there is evidence of a fecal-oral transmission. And there, this photo here shows the S spike, and there is the ACE2 that it's attaching to. This slide here depicts the renin-angiotensin system of what actually happens, because the ACE molecule that's on epithelial cells is what the SARS-CoV attaches to. And the ACE, then to understand it better, you need to understand what the renin-angiotensin system actually is. And this, what the slide does, is discussing it. Increased renin release from the juxtaglomerular cells in the kidney is caused by decreased blood flow to the kidneys from ischemia, blood loss, hypotension, sodium diuresis, or excessive sodium loss in urine, beta-adrenergic stimulation. As you can see here, the angiotensin system, angiotensin 1, causes vasoconstriction, hypertrophy, fibrosis, proliferation, and pro-inflammation, oxidative stress. Angiotensin 2, vasodilation, vascular protection, anti-fibrosis, anti-proliferation, anti-inflammation, and nitric oxide. ACE inhibitor, ACE2, is what it attaches to. So it downregulates the ability to protect your body against inflammation. So it's working against the anti-inflammatory process of the ACE2, and that's what causes the disease process of the SARS-CoV. This slide further depicts the inflammatory process of the coronavirus as it shows here. The ADAM17 plays a vital role in the inflammatory process because it helps the release of the tumor necrosis factor and the TMPRSS2, or transmembrane protease serine 2, and the converting enzymes such as the vimentin and the clathrin. And is it believed that these are involved in the binding and fusion process of the COVID-19 virus. And that's what's happening here. When the inflammatory process takes place, these protease comes out, the clathrin, the vimentin, the ADAM17, and the TMPRSS2 is always here, and it is helping with the fusion process of the spike protein to the ACE2 inhibitor that's supposed to be helping you fight off the infection. So this actually stopping that from happening through downregulation. This is part of the cytokine storm that's happening. And once this fusion takes place, there's multi-organ injury that's going to happen in the liver, kidneys, intestines, pancreas, all these organs here that have high expressions of the ACE2 on the lining of the epithelial cell. The SARS-CoV-2 effect on the pulmonary system. The ACE2 is highly expressed in lung alveolar cells. It's spread by respiratory droplets produced by infected individuals. It deregulates the lung protective pathway, which is the surfactant that's on the lung. It deregulates that and stops that from helping you protect the lung alveolar cells and causes viral pathogenicity in the lung, which would cause ARDS or acute respiratory distress syndrome. The virus spreads from the lungs to other organs that are high with the ACE2 expression that we saw on the other slide through blood circulation. So once the SARS is uncoated and it's replicated inside the nucleus and spread throughout and enters the extracellular fluid, it goes through the blood to circulate to other organs in the body that have high expressions of the ACE2 inhibitor to cause disease. And this slide shows an individual, hopefully he's not infected with the coronavirus because he is coughing, and those are examples, microscopically, if you could see them, of droplets that comes out when you sneeze or cough. And these droplets can get in your eyes, nose, and mouth if you're close enough to him when he's coughing like that, or anyone else that has it. This slide shows the ACE2 expression in the respiratory airways. As you can see on the slide, the SARS can cause multiple system infections in various respiratory tracts of humans and cause acute respiratory syndrome. It has been reported that smokers have a higher expression of the ACE2, and so do people who have comorbid conditions of cardiovascular disease. And this is why these patients have a higher mortality, because they have a higher expression of the ACE2, and that's exactly what the COVID cleaves to. As you can see on the bronchus, there's the ACE2 inhibitor, ACE2 protein that's attached on these cells, but there are more in smokers and cardiovascular disease. So there would be more SARS viruses attached here, cleaving and causing replication inside these cells and going into the extracellular fluid. This slide shows an X-ray of a normal lung on the left and the hallmark sign of ARDS, which is the ground glass opacity. As you can see here, it's got the arrows showing this opaque and ground glass. This is the hallmark sign of ARDS. This is actually the X-ray of a 28-year-old man that's been infected with the COVID-19 over 4 days. So this is probably someone who is a smoker, because this is a very quick way to get the ground glass opacities. So this is probably someone that's a smoker. But anyway, this is an example of what ground glass opacity of ARDS looks like. This slide is about the SARS-CoV-2 and the cardiovascular system. The SARS-CoV-2 uses the ACE2 receptor to enter the host cell, and the ACE2 negatively regulates the renin-angiotensin system by inactivating the angiotensin II. It's associated with a high inflammatory response, induced vascular inflammation, myocarditis, cardiac arrhythmias, cardiogenic shock. The risk factors are male gender, advanced age, hypertension, diabetes mellitus, cardiovascular disease, cerebrovascular disease, and acute cardiac injury. In fact, acute coronary syndrome and myocardial infarction were noted to occur with SARS. Also, reduced cardiac systolic function has also been reported. Myocardial injury is likely associated with the infection related to the myocarditis and ischemia. There's also going to be elevated levels of troponin, D-dimers, leukocytosis, C-reactive protein, procalcitonin, and brain natriuretic peptides, BNP, which suggests congestive heart failure and cardiogenic shock. Here we're looking at systemic inflammation and direct viral infection. As you can see on this slide, the systemic inflammation happens as soon as the COVID enters and gets attached to the ACE2 on myocardial cells. Direct viral infection. The incidence of mortality is 50% with cardiac injury. With stroke, the mortality is 40%. There's myocardial infarction that happens as a result of the thromboembolism, and that mortality is 30%. At this point, you're going to definitely have arrhythmias that will actually prove that you're having a myocardial infarction. This slide further goes into the increased metabolic demands when you're infected with the SARS-CoV-19. Direct viral cardiomyocyte toxicity is what's going to happen once the SARS gets inside the myocytes in the cardiovascular system. There's going to be disseminated intravascular coagulopathy and a microthrombi, which we call showering of clots, actually. That microvascular dysfunction and vasculitis causes endothelial injury, which is going to cause myocardial injury noted here and the necrosis. That's going to be manifested on your EKG as ST segment elevation. These pre-existing plaques will then rupture, causing it. There's also going to be hypoxia and that ground glass on the x-ray that you're going to see from ARDS. And that's a hyperinflammatory state at this point. Next, we're going to talk about SARS-CoV and acute kidney injury. The primary pathological finding here is acute tubular necrosis. Risk factors would be older age. You're going to see increased serum interleukin 6 levels, detection of SARS in the urine, and kidney tissues have also been noted in these patients. On the right here is a summary of recommendation statements that's made from the National Kidney Foundation, which is the gold standard for detecting and diagnosing acute kidney injury, or AKI. And their criteria states that AKI is defined as any of the following: an increase in serum creatinine greater than 0.3 within 48 hours, an increase in serum creatinine to 1.5 times your baseline in the last 7 days, and a urine volume of less than 0.5 milligrams per kilogram an hour for 6 hours. This is what the criteria is for AKI in any situation, be it sepsis or any other situation. But certainly in sepsis is where you're going to see these kinds of things. And sepsis is one of the reasons that the SARS-CoV-19 causes sepsis. There's actually 3 stages. Stage 1 is 1 and 1.9 times the baseline for 12 hours. Stage 2 is 2 to 3 times the baseline and more than 12 hours. And stage 3 is 3 to 4 times the serum creatinine is 3 or 4 times the baseline, and is also accompanied by no urine output or anuria for greater than 12 hours, or 0.3 milligram per kilogram an hour for more than 24 hours. And at this stage, it's determined that you have a decreased chance of life and you may even die once you get to this stage. Even with continuous renal replacement therapy, the outcomes are not good at this point. This slide shows the inflammatory process and the actual cytokine storm that's happening with SARS and acute kidney injury. There's elevated inflammatory markers such as the C-reactive protein and interleukin 6. As you can see here, this cytokine storm on this photograph is actually showing you exactly what happens. There's going to be endothelial damage, pod site localization, proximal tubule localization, mitochondrial dysfunction, and all of this is going to equal acute tubular necrosis in the kidneys. At this point, the patient will definitely have ARDS and be on mechanical ventilation and maybe even extracorporeal membrane oxygenation called ECMO if and nitrous oxide oxygenation to dilate those lungs and perfuse the body and hopefully prevent this action from happening. At this point, we're purely on a defensive mechanism. The COVID 19 has replicated itself inside the cell. It is now extracellular and attached itself to other ACE2 inhibitors on other cells, such as the myocardial, and you're going to have myocardial dysfunction, arterial underfilling, venous congestion, because the kidneys simply aren't working. So you absolutely have to be on a continuous renal replacement therapy to get that fluid out of the body because the veins from this hypercoagulability state, the semipermeable membrane is porous and fluid is leaking outside of the cell, causing decreased oncotic pressure, and there is nothing to keep that fluid inside the veins. It is totally in the tissues. These patients have third spacing, there's endothelial damage, microthrombi, rhabdomyolysis at times, microembolism, which is the showering of clots, and definitely, which we hope wouldn't happen, but kidney infarction. So treatment, specific options exist for acute kidney injury secondary to COVID-19, which is largely supportive. Prevention and management of AKI and identification of the potential indication and use of renal replacement therapies or RRT and sequential extracorporeal therapies mentioned earlier are based mainly on the clinical experience of the nephrologist and the intensivist in the ICU because these patients will definitely be in the intensive care unit. The AKI strategies are adapted empirically for these patients, and there needs to be more research in this area because those criteria are quite old, but it's all we have right now at the AKI from the National Kidney Foundation. That's our gold standard of 2012, and that's what we really use. This slide here shows further treatment of medications and their side effects, cardiovascular usually in nature, that's used to treat the COVID. And the goal of it is to inhibit the RNA duplication. We would hope we could prevent the attachment altogether. But if you can prevent the RNA duplication, you have a good chance of that virus not doing any damage. Patient may be sick, but it won't do any damage because it can't live outside of the cell unless it's duplicated. So if you can prevent that from happening, that has to be the goal. And then one of the drugs that's mainly used on that is remdesivir. Remdesivir inhibits RNA duplication. It was originally developed to treat Ebola. It improves pulmonary function and decreases the viral load. Optimal dosing, though, is still under investigation. So the optimal dose for remdesivir is is variable depending on the patient's condition, and certainly if you have acute kidney injury, the dose has to be lower. So there may not be as good of an effect with remdesivir because we can't get the right dosing because of the kidney injury that's happening. Other medications, Plaquenil increases the QT interval. That's the antimalarial drug that is not used hardly at all because these patients are having cardiac events, and increasing the QT interval would not be indicative of using this medication. There's also an anti HIV medication that's being used here, Loprinir, but that causes AV blocks. So you can see there's a lot of medications here, erythromycin, that causes QT interval prolongation, and then the other one here causes hypertension. So a lot of the medicines that can actually inhibit the RNA also cause cardiovascular issues. So, in conclusion, um, we can see that the SARS enters the cell by binding to the ACE2 that's highly expressed in the lung, alveolar epithelial cells, cardiac myocytes, vascular endothelial cells, and other organs in the body. Low low blood pressure is common with this disease process. It's induced by vasoconstriction and stasis, together with endothelial injury affecting the oncotic pressure inside the cells. Hypercoagulability that causes this clotting cascade, thrombosis, is severe in these patients. As you can see on this photo that's depicted, this excessive immune response. The cytokine storm just comes on very strong. These are all elevated. You have a local and systemic inflammatory response, a systemic response, and and multiple organ failure that's happening here, hypercoagulability, activation of fibrinogen, and all these you can see they're all elevated. D dimers, just throwing of clots, lab draws off the charts on levels of these, endothelial injury on these patients, their third spacing, lots of fluid, not in the vascular space, further exacerbating and causing hypovolemia. And there's also hypoxia, pulmonary embolism, and ARDS. The virus induced inflammatory responses, including the excessive expression of cytokines, excessive recruitment of inflammatory cells, and insufficient interferon response, which you need to be on point here, and the possible production of autoantibodies are deemed to be vital factors in this disease process. These pro-inflammatory cytokines are elevated in the plasma proteins with SARS. Significantly increased concentration of these were found in patients with severe disease. Thank you for viewing my PowerPoint, and as it says here, it always seems impossible until it's done. Thank you so much for viewing.